Epilepsy, seizure types, symptoms and treatment options. A seizure is usually defined as a sudden alteration of behavior due to a temporary change in the electrical functioning of the brain. In epilepsy, the brain's electrical rhythms have a tendency to become imbalanced, resulting in recurrent seizures. In patients with seizures, the normal electrical pattern is disrupted by sudden and synchronized bursts of electrical energy that may briefly affect their consciousness, movements or sensations. Epilepsy is usually diagnosed after a person has had at least 2 seizures that were not caused by some known medical condition, such as alcohol withdrawal or extremely low blood sugar. For example, if a seizure starts from the right side of the brain in the area that controls movement in the thumb, then the seizure may begin with jerking of the left thumb or hand. Primary generalized seizures begin with a widespread electrical discharge that involves both sides of the brain at once. Some partial seizures are related to head injury, brain infection, stroke or tumor, but, in most cases, the cause is unknown. If the first seizure occurred at the time of an injury or infection in the brain, it is more likely the patient will develop epilepsy than if the seizure did not happen at the time of injury or infection. Epileptic seizures may be tied to a brain injury or genetics, but for 70% of epilepsy patients, the cause is unknown. The Epilepsy Therapy Project notes that 10% of people will have seizures in their lifetime. Epilepsy affects more than 300,000 children under the age of 15, and more than 90,000 young people in this group have seizures that cannot be adequately treated. The onset rate starts to increase when individuals age, particularly as they develop strokes, brain tumors or Alzheimer's disease, all of which may cause epilepsy. Brain injury or infection can cause epilepsy at any age. The Epilepsy Foundation also reports that 70% of children and adults with newly diagnosed epilepsy can be expected to enter remission after having gone 5 years or more without a seizure while on medication. According to the National Institute of Neurological Disorders and Stroke, 20% of epilepsy patients have intractable seizures, seizures that do not respond to treatment. Children may be born with a defect in the structure of their brain, or they may suffer a head injury or infection that causes their epilepsy. In people age 65 and older, stroke is the most common known cause, followed by degenerative conditions such as Alzheimer's disease. Often, seizures do not begin immediately after a person has an injury to the brain. Diagnosis: a doctor makes his or her epilepsy diagnosis based on symptoms, physical signs and the results of such tests as an electroencephalogram, EEG, computed tomography, CT or CAT scan, or magnetic resonance imaging, MRI. Treatment: epilepsy may be treated with antiepileptic medications, AEDs, diet therapy and surgery. Medications are the initial treatment choice for almost all patients with multiple seizures. Some patients who only have a single seizure and whose tests do not indicate a high likelihood of seizure recurrence may not need medications. The medications treat the symptoms of epilepsy, the seizures, rather than curing the underlying condition. They are highly effective and completely control seizures in the majority, approximately 70%, of patients. The drugs prevent seizures from starting by reducing the tendency of brain cells to send excessive and confused electrical signals. Both diets have been shown to reduce seizures in approximately half the patients that are identified to be appropriate candidates. These are mainly children with refractory epilepsy who are not surgical candidates. While approximately 70% of patients have well-controlled seizures with these modalities, the remaining 30% do not and are considered medically resistant. Neuroscience nurses: in patients whose seizures are medically resistant, surgery provides the best chance of complete control of seizures. However, not all patients with refractory epilepsy are suitable candidates for surgery. Furthermore, The epileptic region should be in a part of the brain that, if removed, is unlikely to result in major neurological complications. Pre-surgical evaluation consists of a 1 or 2-phase process to determine if surgery is the best option and can provide good seizure control with minimal risk. Phase I involves all non-invasive, non-surgical tests. Phase II testing involves invasive tests, requires surgery, that are used in select patients. Adult and pediatric epilepsy patients are evaluated by epileptologists who determine the necessary and appropriate tests on an individualized basis. The following tests may be required in the Phase I evaluation: electroencephalography, EEG. This is the initial test performed in every patient and is usually done as an outpatient procedure, pictured here. Although most patients do not have seizures when the EEG is being recorded, they often have abnormal brain activity in the EEG, spikes or sharp waves, that indicates they have a tendency to have seizures. The location of this activity allows the physician to determine whether patients have partial or generalized seizures. Inpatient video EEG monitoring in adult and pediatric epilepsy monitoring units, EMU. This is the most important pre-surgical test and is performed with electrodes attached to the scalp, non-invasive monitoring. Patients are admitted to the hospital for several days and the purpose is to record seizures with simultaneous video and EEG. Results of video EEG monitoring are compared with those obtained from the other tests to see if they all point to the same region of the brain as being the origin of epileptic seizures. As there is more risk from invasive monitoring, the decision about the necessity for a Phase II evaluation is usually made by the epilepsy team as a whole and discussed in detail with the patient. After surgical placement of electrodes, the patients are transferred to the epilepsy monitoring unit and epileptologists perform video EEG monitoring in a similar fashion to the Phase I monitoring. These electrodes are able to record brain activity along the entire length of the implanted wire. With this approach, multiple depth electrodes are implanted in a specific pattern that is individualized to the patient. After a sufficient number of seizures are recorded, brief electrical stimulation is provided through each electrode separately to determine the normal function of the part of the brain underneath the electrode. The purpose is to map out critically important areas of the brain such as those necessary for motor, sensory and language functions and to determine if there is any overlap with the seizure-generating regions. Surgery involves placing a neurostimulator in the skull and connecting to 2 electrodes that are placed either on the surface or into the brain, in or around the area which is deemed to be the likely onset region for the seizure. This surgery is generally reserved for patients who are not a candidate for surgical resection, since the RNS improves seizure control but rarely stops seizures from occurring.